All right, let's talk about the respiratory system now. And the first thing we have on your handout is a thoracentesis. Pre-procedure, chest x-ray and vital signs, and positioning is important. Well, one position you are probably most familiar with is to have the patient sit up over the bedside table. And sometimes, though, they can't sit up. And if they can't sit up, you have them lie on the unaffected side, okay, with the head of the bed up a little bit. And remember, the patient must be very still and no coughing, no deep breathing or anything. If they feel like they're about to sneeze, they need to tell you, okay, because if they jerk too much during the procedure, the needle can go too far. Now, I have another lovely picture drawn, okay? This is a lung, it is not an ear, okay? And as you notice, you've got two linings there, the visceral and parietal pleural. And I do not have these linings drawn correctly. Normally, the two linings are supposed to be slam dunked together and vacuum packed. Now, when I say vacuum packed, what do I mean? There's no air in there. The only thing that's supposed to be between those two linings is a little bit of lubricating fluid, so when the linings move together, they do so smoothly, and therefore it doesn't hurt, okay? Or you don't hear a friction rub or all that kind of stuff, okay? Things happen, though. Blood and air or fluid or whatever can accumulate in the pleural space, and the more we have accumulation in here, it compresses the lung, and eventually the lung will collapse. Either a part of it will collapse or the whole thing can collapse. So that stuff has got to be removed, and so that's why they may do a thoracentesis. On your handout, the fluid is being removed from the pleural space. Pleural space. And as the fluid is removed, the lung should do what? Re-expand. Re-expand. Since you are removing fluid, the patient could go into a fluid volume deficit. We're pulling fluid. Therefore, you should be checking the vital signs like blood pressure and pulse. In post-procedure, we do another chest x-ray. Well, there's a couple of reasons. We want to see if that lung is re-expanded, right? But also, we want to make sure that they haven't made the pneumothorax worse, because you know, you can go too deeply with the needle. All right, now then, after a thoracentesis, they can take the needle out, okay, and then they would put like an occlusive dressing, like Vaseline gauze or something over that little puncture site, or they can leave tubes in, can't they? Okay, chest tubes. Now, they have lots of different types of systems out there. 1-bottle system, 2-bottle, 3-bottle, but most of us are familiar with the plastic box that hangs on the side of the bed. And the plastic box emulates a 3-bottle system. But as you can see, my picture, I have a 1-bottle system because that's the easiest way to teach chest tubes, okay, and how chest bottles work. So the doctor is going to go in here, all right, and put a tube in, and then they're going to expect us to know to hook up the chest bottle, all right? And you'll have a tube that comes all the way down in here, and you'll hook it up. All right, so let's look at some questions here. What has happened that the patient even needs a chest tube? The lung has collapsed. The lung has collapsed, and the patient will have an occlusive dressing at the insertion site around the tube we're talking about. And what is the purpose of the water seal? To promote one-way flow out of the pleural space. To promote one-way flow out of the pleural space. Now let's talk about this. As you can see in my chest bottle, I do not have any water in it. That's bad, okay? Because what's going to happen is if there's any air that comes out, it's going to go down in here and then go what? Out, or what could happen that's even worse, what? Air from out here can go down and go back into the pleural space. That's the number one thing I'm worried about. That's why you have got to have a water seal. So I put some water in it, and the box will tell you exactly how much water to put in it, okay? Well, look, as long as I have a water seal now, the tube's underwater, the part that's going to the patient, air from out here cannot do what? That's right. It can't go in here and dive underwater and go back up. Now, can it? No. So that's why the purpose of the water seal is to promote one-way flow out of the pleural space. And that's why we have an air vent. So when it bubbles here, the little air bubbles and air can escape through the top. Now, do you want to see fluctuation in the water seal tube? Yes. You want to see fluctuation with respiration. It's just a slight fluctuation. That means you've got a good connection when you see that. A good connection. Now, what are we watching the daily chest x-rays for? Re-expansion. Re-expansion. And the fluctuation will stop when the lung has re-expanded, if there's a kink or a clot in the tubing, or if the suction is not working properly. All of those things are true. Now, why is it important to keep the bottles, Pleurovac, below the chest? To promote gravity drainage. To promote gravity drainage. All right. Now, the next question says, what do you do if the tubing becomes disconnected? Okay, let's pretend that you're turning the patient and you didn't have enough slack in the tubing and it popped apart at the connector site right there. Well, as long as it's apart, air from out here is doing what? Rushing into the pleural space and could recollapse your lung. Wouldn't it be wonderful if there was a sterile connector just sitting there in the bedside in the little package? So you could just hook up the sterile one. But if there's not one, what should you hurry up and do? Reconnect it. Reconnect it. And you're saying, well, it's not sterile. But hey, I'm still alive, aren't I? A pneumothorax can kill you. All right, so we reconnect it and get your patient to coughing and deep breathing good, okay, to re-expand the lung, get that excess air out that could have gone in. Now, what do you do if the bottle breaks and the water seal is lost? Let's say this one bottle system is sitting at the bedside. Normally what they do, if you are working in a hospital where you have a doctor still using the glass bottles, they'll put it in a cardboard box and tape it to the floor, okay, so you won't kick it as much. But what if you do kick it and it breaks or cracks and all the water pours out? You don't have a water seal anymore. So air from out here, again, is doing what? Rushing in. Tell the person sitting next to you how you would handle this situation. Wouldn't it be wonderful if there was another sterile bottle just sitting there, ready for you to pull these tubes out and then rehook it back up just like you're supposed to do? That's the perfect answer. All right? But what if there's no bottle there? What should you do right then? I'm scared of clamping. I'll tell you why in just a second. Besides, let me tell you this. If you ever do clamp a chest tube, you only clamp it for a couple of seconds. Because if you clamp a chest tube on somebody who was leaking air, you just trapped everything in there. If you clamp it, nothing can come out. And not only are they going to get a pneumothorax, it's going to be a tension pneumothorax. And now they have a mediastinal shift and their trach is sitting on the side of their neck. Not good, right? Okay, so we're scared of clamping chest tubes. All right, so what would you do if the sterile bottle wasn't there? Well, you know that ice water sitting at the side of the bed, the little ice pitcher? You grab it, okay, and you stick that tube in that ice pitcher, in that cup of water. It says on your handout, you do whatever you have to do to reestablish the water seal. So there you are sitting at the bedside, in the floor, holding the tube down here, right, with the tube in the cup of water. And you get on the call light and get your friend to do what? Bring you a new system, okay? All right. And when you ask for a new system, everybody at the nurse's station knows what's happened, okay? So everybody comes running to help them. Now, if the chest tube is connected to suction, you're going to see gentle continuous bubbling. That's the suction making it bubble, okay? If you see vigorous excessive bubbling, you need to think air leak in the system. Something's wrong with your system. Don't get me wrong. If I have a pneumothorax, y'all, am I leaking air out of my pleural space? Yeah, that's why I've got the chest tube, is to pull the air out. So in my bottle, will you see bubbling? Yeah, you'll see intermittent bubbling. You're never supposed, it bubbles every time I breathe. You're not going to see continuous bubbling unless it's hooked to suction. Now, continuous, I'm emphasizing that continuous excessive bubbling means there's an air leak in the system. Now, call the doctor if the drainage is greater than 100 cc's per hour, or the drainage becomes bright red, or there's a sudden change in it. Okay, anything different, assume the worst. Now, do not milk or strip a chest tube without a doctor's order. They do not want a brand new nurse stripping chest tubes. And all that is when you put some lotion on your hand, you hold the tube in place at the insertion site, okay? And then you squeeze the tube and pull down. That forms a suction and can dislodge clots. But it also can traumatize lung tissue in there. They don't want brand new nurses doing that unless you have a doctor's order. Never clamp a chest tube without a doctor's order. Now, when the doctor removes the chest tube, the patient will need to take a deep breath and hold or Valsalva. When you do any of those things, what just happened to intrathoracic pressure? Increases intrathoracic pressure. Increases intrathoracic pressure. And when you increase the pressure in here, air from out here can't do what? Go in. I don't want air going into my pleural space. Okay? And then once the tube is out, you hurry up and put a petroleum dressing over it, and then put a 4x4, dry 4x4 on top of that. See, it's got to be occlusive. That's why you put the Vaseline gauze on it first, and then you put that. Okay, one more scenario here, and then I'll hush about chest tubes. What if you are taking care of a patient one day and you decide you're going to change the dressing around the insertion site because it's yucky and brown, has old drainage on it? Well, you pull off each layer, one layer at a time, just like you were taught with sterile dressing change, okay? But it's stuck and it pulled out the whole tube. Now here's a tube here and you're looking at a hole. What are you going to do? Ask your friend. Reinsert? No, you just became a pulmonologist just like that, didn't you? Okay? Don't reinsert it. You either slap your hand over the hole. It's one thing they'll say do. Or you can just pinch it together is another way they'll describe it. Either way, you're closing up the hole, right? And you get on the call light and you tell somebody to hurry up and bring you some sterile Vaseline gauze. And when you get that sterile Vaseline gauze, how many sides do you tape down? 3. Only tape down 3 sides. Because you want the 4th side to be free, so air can escape if it needs to. Some textbooks will call that the flutter valve. The area that you're leaving open, they call it a flutter valve. Because, y'all, think about it. You just pulled out their tube, and you put the Vaseline gauze on there and tape down 3 sides. But if there's some air in here that needs to come out, don't you want it to be able to do so? Yeah, you want it to be able to do so because you don't want a tension pneumothorax. You see, when I was in nursing school, they told us to tape down all 4 sides. But then they found we were trapping air in there and actually promoting a tension pneumothorax. So that's why you leave one side open. All right, enough on that. Let's look at a pulmonary embolus now. Pulmonary embolism. This can occur if a patient becomes dehydrated, has venous stasis, or has been taking birth control pills. All of those things make your blood get thick. A thrombus forms, dislodges, now we call it an embolus, and it goes to the lungs. Signs and symptoms. The number one thing, hypoxemia. When you're hypoxic, you know you're short of breath. The patient may have a cough, and they have an increased respiratory rate. Now, some lab work that they can look at is called a D-dimer. It's increased with pulmonary embolus. It's a blood test. It looks at coagulation activity. You see a D-dimer done a lot with DVTs too, to see if how their coagulation activity is. All right. Now, in the little square out to the side, it says if you have a little pulmonary embolus, you may be asymptomatic, medium, symptomatic, large one, you may die immediately. Now, a VQ scan is another test they may do for diagnosis, a ventilation perfusion scan that can detect an embolus done in radiology, and it looks at blood flow to the lungs. Dye is used, and anytime they're using dye, you know you got to ask them, are you allergic to iodine or shellfish, okay? Remove jewelry from the chest area so that you will not get a false result. If they've got a necklace hanging down here and they're having a scan, that's going to occlude the scan, isn't it? Okay, so jewelry from the chest has to go. All right, hemoptysis, that's just coughing up blood. And if you had a clot in your lungs, what do you think your pulse would do? Increase. You're hypoxic. Patient may have chest pain that may be sharp and stabbing. They're, of course, going to look at the chest x-ray and the lung scan. Now, if you are hypoxic, what is going to happen to the blood pressure in your lungs? Goes up. You get pulmonary hypertension. Y'all, the number one cause of pulmonary hypertension is hypoxia. The number one cause of pulmonary hypertension is hypoxia. And as you know, there are lots of diseases in the world where you have hypoxia, right? Now let's think about how this hypoxia is going to affect the heart. Look out to the side. Hypoxia causes an increased lung blood pressure, which increases workload on the right side of the heart. Y'all think about that. The right heart is not used to pumping against high pressure, is it? Now all of a sudden you got high blood pressure in your lungs and the workload just went up because it's having to pump harder against that pressure. So therefore, now my patient is at risk for what? Right-sided heart failure. Right-sided heart failure. Well, if you have a pulmonary embolus, what's going to happen to your PO2? Decreases. Fever, yes. White count, up. Inflammation. Treatment. The number one thing we have to remember is prevention. You know, that's why we ambulate. That's why we hydrate. That's why we use the SCDs, right? The sequential compression devices, or some people call them pneumatic sequential compression devices. That's why we use a lot of Lovenox now in bedridden people. Okay? Oxygen, of course. Ventilator, maybe. It depends on how big of an embolus you have. Watch the right ventricle for failure, right? Yeah. This is when the doctor may put a Swan-Ganz catheter in to monitor the right side of the heart. Swan-Ganz catheter to monitor the right side of the heart. Check the ABGs, of course, and they're probably going to bolus them with some heparin to start with, IV, aren't they? Then you get a continuous infusion of it. And then, if you're started on heparin, you're probably going home on Coumadin. Now, can you be on heparin and Coumadin at the same time? Yeah. As they're bringing down the heparin, you're bringing up the Coumadin. The doctor writes an order to DC heparin, IV. How do you do it? Slowly. You taper it. What would happen if you just walked in the room and said, the doctor DC'd your heparin, I'm going to cut it off. Bam, off. Now what does your patient have? A clot. They're immediately going to clot, and then they're going to throw it, and then they're going to have a pulmonary embolus. You never suddenly stop heparin. It has to be tapered. And another drug that we have there is Lovenox. That's given a lot too. All right. And then we're going to decrease pain as well. All right, let's look at chest trauma. The general treatment for any chest trauma is going to be chest tubes, oxygen, chest x-rays, ventilation, and elevate the head of the bed. Now, a hemothorax pneumo. Hemo means blood. Pneumo means air, right? This is when blood or air has accumulated in the pleural space. So what has happened to the lung? It collapsed. With a hemothorax, the signs and symptoms depend on the size, but you're going to have decreased breath sounds on that side and respiratory distress. Pneumo, you feel the subacute air, I should say. You feel the subacute air. Patient may have pleuritic pain and also an increased respiratory rate. Now, it is just a rule that if you work in the ER, you never pull out a penetrating object, okay? Because if a patient comes in with a machete sticking out of their side and you pull it out, what did you just allow air to do? Go in. So what should you tell them to do? Have a seat. You can have 2 seats since you have a machete sticking at your side, right? Okay? Now, the point is you leave it in place because that is forming a seal. I guess the worst case I ever saw was somebody that worked at a furniture factory, and a board at the furniture factory shot through him. And he would, to put him in the helicopter, they had to saw off the board, okay? But they left it in place so they could get them to surgery because they didn't want to disturb it because of the seal that it had. Another example, I've seen a little boy before who fell on the playground and a pencil went into his heart. And it broke off, thank goodness for him, okay? Because normally, if somebody, a layperson had come up on somebody who had a pencil sticking out, what would most people do? Pull it out and they would have hemorrhaged. They left it in place. It formed a seal so they couldn't bleed out, got him to surgery, okay? Also, think about the eye and penetrating objects. In this class, I used to take Charms blow pops and throw them out in the afternoon, okay, to wake everybody up. But the only people that knew what to do were the Louisiana people because they knew about Mardi Gras, right? And Mississippi, I was knocking people in the head. And I got scared that I was going to throw a lollipop and it was going to land in somebody's eye. So let's pretend that I threw out a bunch of Charms blow pops and a watermelon sucker lands in your friend's eye. How would you handle this situation? Ask your friend. Well, you're not going to say, oh, it's watermelon, I want it. No, right? What do? What you do is you take a cup and you place it over the side because do you want anything to touch it? No. You don't put any kind of dressing over it, nothing. You put a cup over it and they have to ride to the ER like this, right? Yes. All right, now, thoracentesis, chest tubes, and daily chest x-rays for these type of hemo and pneumothorax. Now, here's the big bad one. If you got to get a pneumothorax, you want a plain one, okay? You do not want a tension one caused by trauma or PEEP. And you'll see in just a second how those things can cause it. This is when pressure has built up in the chest or pleural space and has collapsed the lung, and pressure pushes everything to the opposite side, so you wind up with a mediastinal shift, okay? Now then, let's look at think about PEEP. Since trauma's first, let me mention that. If you've got a blunt trauma to the chest and you don't have an opening on the outside, then that could cause trouble in here and pressure could build up. But PEEP, that's positive end expiratory pressure. The ventilator is exerting pressure down into the lungs. So could you blow out a lung with PEEP? Yeah, and there's no external wound for the air to escape from, so naturally pressure builds up. So the pressure is the key word with the tension pneumo. Signs and symptoms: subacute air, absence of breath sounds on one side, asymmetry of the thorax, and respiratory distress. This can be fatal as accumulating pressure compresses vessels, decreases venous return, and therefore decreases cardiac output. Well, if your heart isn't putting out blood, can you live? No. That's why it's fatal. Treatment: large bore needle is placed in the second intercostal space to allow excess air to escape. Find the cause: chest tubes. You see how they're going to put one big old needle up here because air is going to come up, isn't it? So they put one up here, and then they put another chest tube down here in case there's any fluid or whatever that needs to come out. All right. Open pneumo. This is when we have a sucking wound. You can actually hear the air moving in and out. Opening through the chest allows air into the pleural space. Treatment. You had the patient inhale and exhale forcefully or Valsalva. Or you can say take a deep breath and hold or hum. When you're doing any of those four things, the next statement tells you how it helps. All of these will increase intrathoracic pressure so no more outside air can get in the body. Then you place a piece of petroleum gauze over the area and take down how many sides? 3, because you want the fourth side to act like a air vent or flutter valve. Air vent or flutter valve. So in case there's some air in there that needs to come out, you want it to be able to do so. You have the patient sit up if they can to expand the lungs, but if it's a trauma patient, you know you keep them flat, right? Now, fracture of the sternum and ribs, most common injury. Signs and symptoms, tenderness, crepitus, that's the bones grating together, and shallow respirations. Well, I'm breathing shallow because it's hurting me to breathe. So which acid-base imbalance am I going to have? Respiratory acidosis. Respiratory acidosis. Treatment. Non-narcotic analgesic. Why, if I'm hurting, are they giving me a non-narcotic? I don't want to suppress the respirations even more. I don't want to suppress the respirations. All right, it says on your handout to support the injured area with a sandbag. Well, that would be like if you were out in the field, right? You just don't want that chest wall moving back and forth because that's going to cause more trauma. You may just turn them on that side to stabilize it, okay? Would be another thing you could do. All right, to limit movement. These patients will usually be put on the ventilator with PEEP, positive end expiratory pressure. Now, when you are on PEEP, you're on the ventilator, and you are on a rate. You're not breathing on your own, okay? They've put you on a rate. And look at the next sentence. On end, this is how PEEP works. On end expiration, the ventilator exerts a pressure down into the lungs to keep the alveoli open, which improves gas exchange and decreases work of breathing. In this patient, PEEP expands the thorax and realigns the ribs so those bones can start growing back together. Put a star by that. That's the number one reason this person's got PEEP, is to realign those ribs. Now, since we're talking about PEEP, let's go ahead and talk about BiPAP too. It's used a lot with pulmonary edema, and they may use this prior to intubation. Y'all, this can be a mask or it can be the biprongs, can't it? And it's exerting pressure, okay, to keep the alveoli open. Keep the alveoli open. Improve gas exchange. Now, another thing you may see is CPAP, continuous positive airway pressure. They're breathing on their own here. Now, with CPAP, y'all, it might be a mask, or they could still be intubated, but breathing on their own. With PEEP, you got to remember, they're on a rate on the ventilator because PEEP is a very timed thing. When, with PEEP, is the ventilator going to exert pressure on end of expiration? So that's why they've got to be on the ventilator, because the ventilator is really monitoring their respiratory cycle so it'll know exactly when to shoot that pressure in there to keep the alveoli open. Now, anytime you see PEEP, CPAP, or another setting that you see on vents nowadays, pressure support, your priority nursing assessment is to check bilateral breath sounds. Bilateral breath sounds every hour. Bilateral breath sounds every hour. Priority assessment, because y'all, with these 3 procedures, are you pushing pressure into their lungs? Yes. What could we do to their lungs? Blow it out. Pneumothorax, you can cause a problem, can't you? I've seen somebody that this happened to. Both lungs blew out because the person was very elderly, and too much PEEP had been ordered, and they had sub-Q emphysema from here all the way down to their big toe and everywhere in between. Just a fatal complication. You know, normally when somebody has sub-Q emphysema, it's around in a certain little spot. It's not total body, all right? Even I knew something was wrong then, okay? All right. Now, flail chest, multiple rib fractures. Well, if you've got multiple rib fractures, I guess you're going to be in pain. And you're going to also have something called paradoxical chest wall movement, or a seesaw chest. You know, y'all, you and I like for the chest to rise and fall symmetrically, right? If it's seesawing, it's not symmetrical. Okay, this is when the chest sucks inwardly on inspiration and puffs out on expiration. Okay, you see, y'all, when you inspire, your chest, your thorax gets bigger. It's not supposed to suck in, all right? So what happens is the normal size doing what it's supposed to do, and the other side's doing just the opposite. So you get the seesaw going on. Dyspnea, cyanosis, increased pulse. Treatment, stabilize the area, intubate, ventilate, and the positive pressure ventilation will stabilize the area as well. All right, let's pretend we've got somebody with COPD, chronic obstructive pulmonary disease, chronic airflow limitation it's sometimes called. What's the most important thing you learned about the COPD person in oxygen? Don't give them too much, because if you give them too much, they will stop breathing. As long as that person is hypoxic or has too much CO2 in their body, they'll keep on breathing, won't they? But the minute you satisfy that oxygen need that they have, they quit breathing on you. They're not like you and I. All right, now we've got a COPD patient in the hospital that has just coded. Do you ambu them with 100% O2 or 2 liters of O2? Ask your friend. Now tell me. 100%. You're saying, but Marlene, they've got COPD. You just got through saying you don't give COPD people too much oxygen or they'll stop breathing. If they've coded, they've already stopped breathing, right? So we don't worry about that anymore. And are you going to do much good ambuing somebody with 2 liters of O2? No. So here's a good rule of thumb to help you pass your test. Are you ready? Never withhold oxygen on dead people, okay? Okay. Enough on the respiratory system.